Okay, we will continue with prostate cancer part 26, osteoporosis and androgen deprivation. Osteoporosis is defined as low bone mineral density and reduced bone mass that weakens the bone and increase the risk of bone fracture. Medical and surgical castration can cause osteoporosis. Anti-androgen monotherapy and estrogen do not cause osteoporosis. Most of the bone loss from androgen deprivation therapy occur within first year of therapy. A long duration of anti-androgen or anti-androgen deprivation therapy is associated with greater decline in body mass, bone mineral density, and high risk of skeletal fracture. Bone density might decline as much as 10% during the first year of therapy by 1 to 3% per year thereafter. Men on long-term ADT have at least a 5-fold higher risk of osteoporosis-related fracture than healthy age-matched control. Some fracture occur during the first years of ADT. Pathological fraction in men receiving ADT have been correlated with decreased overall survival. Most osteoporosis-related fractures are caused by falling. ADT causes fatigue and reduces muscle masses, which increase the risk of falling. Men about undergo ADT have a lower body mass, bone mineral density than healthy age-matched control. Thus, they are at risk of osteoporosis and even before ADT is started. Osteoclast inhibitors such as bisphosphonate and denosumab reduce the risk of osteoporosis and skeletal fracture in men on ADT. That's testing for osteoporosis in men on ADT, history and examination assessment for factors, risk factors. Since most osteoporosis-related fractures are caused by falling, it is important to assess the patient risk for falling and for osteoporosis. Risk factor for osteoporosis like hypogonadism, current smoking, high caffeine intake, alcohol intake more than 3 drinks per day, steroid use, physical inactivity, thin body habits, older age, vitamin D deficiency, low calcium intake, chronic metabolic acidosis. Risk factor for falling urinary urgency or frequency cause more visits to bathroom and thus increase circumstance when fall can occur. Impaired mobility, muscle weakness, poor balance, medication causing sedation or dizziness, orthostatic hypotension, impaired vision, impaired cognitive, arrhythmia, and previous fall. All this is considered as a risk factor or risk factors for falling urgency, urinary urgency or frequency. Blood tests might be considered. Blood tests that include serum calcium, creatinine, vitamin D25OH, bone mineral density, usually measured using dual energy X-ray absorptive DEXA, body mineral density, correlate with the bone strength and risk of future fracture. Fracture risk increase exponentially as body mineral density decreases. Body mineral density from DEXA is reported using 3 measures: grams of mineral per area of bone scan, Z-score, the difference between the patient's actual bone mineral density and the expected mineral density of the bone for patients' age and gender, expressed in standard deviation above or below the mean. T-score difference between the patient actual body bone mineral density and the mineral density of the bone of young normal patient of the same gender, expressed in the standard deviation above or below the mean. The World Health Organization fracture risk algorithm, that's known as FRAX, provide the 10 years estimated risk of fracture for men based on the bone mineral density. FRAX risk estimate can be demonstrated or determined using the online calculation tool or paper chart at the FRAX website here. The treatment of osteoporosis in men on ADT based on NOF guideline recommendation for all patients on long-term androgen deprivation DEXA at the baseline and at least every 2 years thereafter to assess bone mineral density. This is a recommendation for all patients on long-term. We can do DEXA at baseline, this at least every 2 years. Adequate dietary intake of vitamin D and calcium recommendation intake, vitamin D 800 to 1000 per oral query per day and 1000 to 1200 milligram of calcium per oral query per day supplement might be necessary to achieve this. Reduce risk factor of osteoporosis, stop smoking, minimize alcohol, caffeine intake, avoid steroid use, engage in weight bearing and muscle strenuous exercise. Minimize the risk of falling in men with urinary urgency and frequency. Consider using portable handheld urinal and condom catheter, diaper, or bedside condom. The National Osteoporosis Foundation (NOF) recommended treatment of osteoporosis when any of the following criteria are met. If the DEXA T-score less than 2.5, the femoral neck or lumbar spine or total hip. If the DEXA T-score is less than 2.5, here recommended the management by NOF, National Osteoporosis Foundation. The second is the DEXA T between 1 to 2.5, the femoral neck, lumbar spine, total hip with either of the following. 10-year probability of the hip fracture more than or equal 3% based on the FRAX. 10 years probability of any major osteoporosis related fracture more than 20% based on the FRAX, or vertebral or hip fracture. When treatment of men on ADT is indicated based on the NOF recommendation above, start denosumab or bisphosphonates. Denosumab FDA approved to increase the bone mineral density in men who receiving ADT and who are at high risk of skeletal fracture. Bisphosphonate, that's a good example. Zoldronic acids and alendronate have both been shown to increase the bone mineral density, specifically in men on ADT. After treatment for osteoporosis is started, the NOF recommended obtaining DEXA in 1 to 2 years and then every 2 years thereafter. Both drugs are FDA approved to treat men with osteoporosis regardless of the cause. Thus, they are not specifically restricted to men on ADT. Denosumab 60 milligram. We have Prolia. The Prolia denosumab 60 milligram subcutaneous injection every 6 months is FDA approved to increase bone mass in men receiving androgen deprivation for non-metastatic prostate cancer and who are at high risk for skeletal fracture. At higher dose frequency 120 milligram subcutaneous injection every 4 weeks. Denosumab is FDA approved to prevent skeletal-related events in patients with solid tumor that are metastatic to bone. Mechanism of action: denosumab is a monoclonal antibody that binds to rank ligand and prevent it from activating the rank receptor. Thus, denosumab prevents bone resorption by inhibiting osteoclast activity. Compared to placebo, denosumab 60 mg significantly improved bone mineral density and reduced the incidence of new vertebral fracture 1.5% versus 3.9 over 3 years of treatment. Prior to treatment, check calcium level, correct hypoglycemia, and perform routine oral examination. Dental examination and appropriate preventive dentistry should be considered in patients with poor oral hygiene, periodontal disease, dental implant, recent dental or oral surgery, or other risk factors that might increase osteonecrosis of the jaw. Those in men at high risk of fracture receiving androgen deprivation for non-metastatic cancer, prostatic cancer, denosumab 50 mg subcutaneous injection in upper thigh, upper arm, abdomen every 6 months with oral administration of at least 1,000 calcium daily and at least 400 international vitamin D3 daily. Side effects: the most common side effects are arthralgia, back pain, nasopharyngitis. Denosumab 60 mg causes severe hypoglycemia in less than 2% of patients. Patients on dialysis or with creatinine clearance less than 30 have high risk of hypocalcemia. Denosumab 60 mg might cause severe hypophosphatemia. Denosumab 60 mg rarely causes osteonecrosis of the jaw less than 1%. During therapy, in men with renal insufficiency, monitor calcium phosphate, and magnesium. Monitor for symptoms of osteonecrosis of the jaw, pain, numbness, swelling in the jaw, or inside the mouth. A preventive dentistry is recommended during therapy. Stopping denosumab 60 mg for invasive dental procedures should be considered on an individual basis. Patients should be transitioned to another anti-resorptive agent if denosumab 60 mg discontinued because vertebral fracture have been reported after stopping denosumab 60 mg. When denosumab is stopped, bone turnover increases above pre-treatment level for up to 24 months after the last dose of denosumab 60 mg. Okay, this is the end of part 26. We'll meet in the last part of prostate cancer.